A very good morning to everyone. My name is Chong. Today, I'm going to present on clinical management of COVID-19 in emergencies. So first and foremost, we have our clocking sheet and also progress notes. These are two very important notes because all the information in both of the forms will actually tell us four important things in our daily clinical management. First and foremost, it will tell us what are the COVID-19 categorization and the corresponding phases. Why is it important for us to know this? Because by knowing the phases, we know what are the oxygen requirement, what are the antiviral, steroid, anticoagulation, and anti-inflammatories. So that's the reason we must know the categorization. Okay. Second, we have the criteria to say when the patient are improving or deteriorating. And the third one, we must know when is the off-tag period for COVID-19 patient. And last but not least, what are the discharge criteria for COVID-19 patient? So we begin with COVID-19 categorization and the corresponding phases. As we can see from this graph, there are three phases that we must know: early infection phase, pulmonary phase, and hyperinflammatory phase. So there are two responses as well: the viral response phase, which begin from early infection, and the host inflammatory response phase begin in the pulmonary phase. As we can see from here, Cat1 and Cat2 patients are associated with early infection phase, Cat3 associated with early pulmonary phase, which is phase 2A, Cat4 patient associated with late pulmonary phase and also early hyperinflammatory phase, and Cat5 associated with hyperinflammatory phase. So these are the criteria. In the pulmonary phase, which is normally happen from day 5 to day 10, we anticipate deterioration in these types of COVID-19 patients. Okay, then how do we initiate the treatment in Cat1 and Cat2 patients? So in Cat1 and Cat2 patients, there are no role for any antiviral, steroid, anticoagulation, or anti-inflammatories. Next, we go into Cat3 patient, which is associated with the early pulmonary phase of the disease. So in Cat3 patient, there's no need of any oxygen. There's role of antiviral, which we need to give favipiravir if there is no contraindications. So let us focus more about the antiviral favipiravir. So for favipiravir, the normal dosage that we need to give the patient is day 100, 1,800 mg BD, followed by day 2 of 800 mg BD, and to complete in 5 days. And as we can see here, there's no dose adjustment for end-stage renal failure patient on regular HD. And the dose adjustment is only for liver dysfunction child C patient. So there are a few contraindications for favipiravir. First and foremost is teratogenic. So that's why we need to do a UPT for all female patients in reproductive age before we start to give favipiravir. And as we can see for here, we must advise patients for contraception for a total of 2 weeks after finishing the dose of favipiravir as well. So what to monitor when we give favipiravir? We need to monitor the side effect, which include the diarrhea, hyperuricemia, elevated LFT, neutropenia, or increased TG. Okay, there are a few drug interactions that we must be aware of when we give favipiravir, which include paracetamol, pyrazinamide, and theophylline. So favipiravir can be given either before or after HD, and we must know that we must stop favipiravir if there is increase of LFT 5 times above the baseline. So these are our antiviral documentation in our ED clocking sheet. So next, we will go into Cat4 and Cat5 patient. In Cat4 and Cat5 patient, as we can see here, they need to start oxygen supplements. Generally, there are no role for antiviral for Cat4 and Cat5 patient, except that in Cat4 patients, which in late pulmonary phases, where the viral response is still there, there's a role for antiviral. Other than that, in Cat4 and Cat5 patient, we need to start steroid, anticoagulant, and we need to identify certain patients who need anti-inflammatories and discuss with ID team. So next, we talk about oxygen. Okay, in Cat4 and Cat5 patients, we need to know what is our target of our SpO2 for all the patients in COVID-19. So the general rule is that we need to maintain the SpO2 of more than 92%, which means it must have at least 93% to 100%. Okay, if there's only evidence of ARDS, we must maintain the SpO2 at 88 to 92%. Bear in mind that when I say SpO2 of more than 92%, it means that the SpO2 should not be interpreted in isolation. You need to interpret it with the clinical condition of the patient. If the patient is tachypnic and the SpO2 is 93%, we should actually escalate the oxygen supplement. When I say 92%, more than 92% means that if the patient is not tachypnic and the SpO2 is 93%, only means that we accept that. So in terms of the target arterial oxygen in our ABG, we must maintain the PaO2 from 80 to 100 of mmHg. If there's only evidence of ARDS, we must maintain the PaO2 of more than 60 mmHg. So next, we are going to talk about steroid. Okay, so for steroid, it actually depends on the patient oxygen requirement. If the patient need nasal prong, up until ventimass 40%, we will start low dose of IV Dexa, which is 8 mg OD for 5 to 10 days. If the patient's oxygen requirement needs ventimass 60%, high flow mask, high flow nasal cannula, or modified CPAP, or even the patient is intubated, we need to start high dose of IV Dexa of 20 mg OD for 5 days, followed by IV Dexa 10 mg OD for another 5 days. So for steroid, okay, usage in pregnant mother is actually depends on the weeks of pregnancy. If the patient is pregnant less than 34 weeks or more than 34 weeks, we need to start Methylprednisolone of 40 mg OD or IV hydrocort of 80 mg BD for a total duration of 10 days. If the patient's gestation is 24 to 34 weeks, we can start IV Dexa of 6 mg BD for 2 days, followed by prednisolone of 40 mg OD, or we can replace it with IV hydrocort of 80 mg BD for total duration of 8 days. So when do we consider methylprednisolone? So for this one, we need to consider the usage of IV methylprednisolone when the patient is young, have less comorbids, and the patients generally have a good prognosis, and the patients is in hyperinflammatory phase or worsening hypoxemia, which require high oxygen requirement. There are a few contraindications for the usage of IV methylprednisolone, which includes systemic fungal infection, cerebral edema in malaria, or a patient known with hypersensitivity to methylpred or any component of the formulation. So this is how we prepare IV methylprednisolone. Bear in mind that one ampule contains of 500 mg. The dosage normally we give, they are divided into two, which are the pulse dose and also the non-pulse dose. For pulse dose, we must give IV methylpred of 250 mg OD for 3 days, followed by IV methylpred of 2 mg per kilo for 2 days, and followed by IV Dexa of 10 mg OD. For the non-pulse dose, we straight away start with IV methylpred of 2 mg per kilo for 5 days, followed by IV Dexa of 10 mg OD. So how do we dilute the IV methylpred? If we give the pulse dose of 250 mg, we must dilute in 100 ml of normal saline and infuse at least more than 30 minutes. If the patient's dosage is less than 250, instead we dilute in 10 ml and infuse with slow bolus over 5 minutes. So what do we monitor when we give IV methylpred? So we must monitor the blood glucose. We aim the DXT less than 10. And we must monitor the blood pressure and other electrolytes like sodium and potassium. There are a few drug interactions that we need to be aware of, which includes the NSAIDs, because IV methylpred will increase the toxic effect of NSAID. At the same time, it will increase the anticoagulant effect of the warfarin. And as we know, most of the anticonvulsants are enzyme inducer. It can decrease the effect of methylpred as well. For digoxin and diuretics, it can increase the hypokalemic effect of the methylpred. Then and for anti-diabetic, as we know, it causing hyperglycemia. So therefore, it can offset the OHA effect of the medication. So next, we are going to talk about anticoagulant. Anticoagulant also actually, when we give, it depends on the patient's oxygen requirement. If the patient needs nasal prong, ventimask 40%, ventimask 60%, or high flow mask, we must give a prophylactic dosage of anticoagulant, which include our subcute Fonda or subcute Clexane or subcute heparin. But in patients who needs high flow nasal cannula, modify CPAP, intubated, generally we start with prophylactic dose, but at this point of time, we should consider treatment dose with other factors to consider as well, which include the high oxygen requirement, whether the patient can ambulate or not, and also patient whether it's obese or not. So these are the chart that I want to show you. What is the prophylaxis dosage for each and every of our anticoagulant? We start with subcute Clexane. So in subcute Clexane, the prophylactic dose actually depends on the creatinine clearance and the BMI. If the BMI is less than 40 and the patient doesn't have any CKD, we will start with 40 mg OD. If the BMI is 40 to 50, we should start with 40 mg BD. And the BMI is more than 50, we should start with 60 mg BD. Okay. So for subcute Fonda, if the creatinine clearance is more than 30, we should start with prophylactic dose of 2.5 mg OD. And for subcute heparin, it also depends on the BMI of the patient. If less than 30, we should start the prophylactic dose of 5,000 unit BD, 30 to 50, 5,000 unit TDS. And if the BMI is more than 50, we should start with 7,500 TDS. Next is the treatment dose. The treatment dose for subcute Clexane, as we can see here, is 1 mg per kilo. Whether it's BD or OD, it depends on the creatinine clearance of the patient. For subcute Fonda, the treatment dose actually depends on the body weight. Instead of BMI, it depends on the body weight of the patient. If the patient is in between 50 to 100 kilo, we should start with the treatment dose of subcute Fonda 7.5 mg OD. If the patient is more than 100 kilo, we should start with higher dose of 10 mg OD. For subcute heparin, actually, we need to give, in treatment dose, we need to switch to Clexane and Fondaparinux. So next, in Cat4 and Cat5 patients, we are going to discuss a little bit on anti-inflammatory. So the anti-inflammatory that we are going to discuss here, it's tocilizumab. Okay. For tocilizumab, actually, these medications is with ID. So what our role in ED is to identify this type of patients and inform ID team so they can start on patients with COVID-19 earlier. So those patients we need to consider to give TOSI are patients with good prognosis, patients in hyperinflammatory phase with rapidly worsening hypoxemia, or in the patients with cytokine release syndrome. The contraindications include pregnancy, systemic infection, high risk of GI perforation, active hepatic diseases, and not recommended for patients with ANC of less than 0.5 or platelet less than 50. And last but not least, it is contraindicated with patients with demyelinating CNS diseases. So for monitoring wise, we should monitor the FBC, liver function test, or interleukin 6 level if available. And other common infusion related reaction includes headache, skin reaction, and hypertension. So this is the dosage of TOSI that we need to give, 8 mg per kilo of actual body weight, or a single dose with a maximum dosage of 800 mg. So how do we prepare the TOSI? Basically, we need to infuse over 1 hour using a dedicated IV line just for TOSI. And if the body weight is less than 30 kilo, we dilute in 50 ml. If more than that, then dilute in 100 ml. So same thing for monitoring wise, just as I mentioned just now. So this is actually a summary slide showing you what is required or what is needed for all Cat4 and Cat5 COVID-19 patients based on the oxygen requirement. So the aim of SpO2, as I mentioned just now, generally it should more than 92% SpO2, but as I said just now, it should not be interpreted in isolation. It should related to the clinical condition of the patient at that point of time. So for steroid usage, as I said just now, is 8 mg for nasal prong until ventimas, 20 mg OD for ventimas 60 and above. For anticoagulation, generally, we start with prophylactic dose, and we should consider to escalate to the therapeutic dose, especially those patients who need high oxygen requirement, which include your high flow nasal cannula and modified CPAP. And we should consider tocilizumab earlier when the patient is in ventima 60% and have good prognosis and in hyperinflammatory phase. So this is a slide showing that what are the blood investigations that we need to take for each Cat3, Cat4, and Cat5 patients. So whether it need to be have a daily or not. Okay. So as we can see here, so for Cat4 patients, for Cat3 patients, we only need FBC, RP, and LFT. Okay. Or upon arrival, and we need to get the blood investigation done daily if the patient is on favipiravir. So for Cat4 patient, as we know, they need oxygen supplements. That's why they need daily ABG to see whether there's worsening of the hypoxemia. And on top of that, for Cat4 patient, we need to take LDH, CRP, ferritin, D-dimer, and TRPT as well to monitor the progress. So for Cat5 patients, as we can see here, so the differences is that daily wise, we need to repeat the CRP because from here, generally, we can know whether the patient's conditions is improving or not based on the daily CRP trend. So from this ED clocking sheet, as we can see, it is included of the investigation upon arrival, which include what I mentioned just now, the oxygen requirement, okay, the steroid usage, the anticoagulant that we need to start. And next, we are going to identify how we recognize actually patients with COVID-19, whether they are improving or worsening. What do we look at? So basically, these are the warning signs of the COVID-19 patients. Basically, it is divided into 4 groups of parameters, which include your symptoms, examination, lab result, and also radiological finding. We start with symptom. If the patient have fever, exertional dyspnea, or persistent cough, or any other persistent symptom like lethargy or poor appetite, it is a symptom of the warning sign of COVID-19. For examination-wise, if the patient is tachypneic with RR more than 25, or the SpO2 less than 95%, or the patient have exertional hypoxia, okay, it's also considered as a warning sign of the COVID-19. In terms of lab, if we see rising trend of the CRP or dropping of the ALC, and if the neutrophil to the lymphocyte ratio is 3.13 or more, it is also considered as a warning sign of COVID-19. And in terms of radiological, when there are features of severe pneumonia or rapidly worsening of the chest X-ray. So as we can see here in our daily progress note, we will document all this important information in as well. As you can see, the symptoms, okay, the examination part, the laboratory part, and also the radiological part. That's why it is at paramount importance for all MO to fill up the daily progress note in order for us to know whether the patient has warning sign or not. So a little bit on CRS. CRS means cytokine release syndrome. It's basically is the extreme part of the hyperinflammatory phase. So the definition of CRS is basically presence of either one of the following, which include if your CRP is more than 100, if your D-dimer is 1000 and above, your ferritin is 500 or more, your LDH is 300 or more, or if you have interleukin 6 level, it is more than 50 pg per ml. So as you can see from here, in our daily progress note, we also do take all these parameters for us to know whether the patient is in CRS or not. It is important to know whether the patient in CRS or not, because first and foremost, we need to know at this point of time, the patient normally will deteriorate, will be worsened, okay? And at the same time, at this point of time, we should consider the usage of tocilizumab, as I mentioned just now. So if the patient is improving, there will definitely improvement of these parameters, okay? Which means there's no symptoms of, there's no fever, no dyspnea, no persistent cough. In terms of examination, there's not tachypneic, no hypoxia. In terms of lab result, you will see increasing CRP trend, increasing ALC, and your neutrophil to lymphocyte ratio will be less than 3.13. And of course, your radiological finding will be, actually, there's not compulsory to repeat unless the patient deteriorate, okay? So next question is that after we know the patient is improving or worsening, why is it important? Because it will change our management. So it will change our management in terms of our medication usage, which include our steroid, anticoagulant, your anti-inflammatory antibiotics, and also your imaging. So we'll begin with your steroid usage. If let's say you identify that the patient is worsening, it's on your left side, you should escalate your steroid. So how do you escalate your steroid? If the patient on nasoprong, Ventimas 40 or higher, you should increase to IV Dexa 20 mg OD. If the patient already on high flow mass or higher, you should consider usage of IV Methylpred. On your right side, if the patient's condition is improving, instead you should de-escalate your steroid. How do we do that? You can change to oral Dexa. Oral Dexa dosage is exactly the same with your IV dosage. So if the patient's of your patient is already on IV Dexa 8 mg, you should just change it to oral Dexa 8 mg. And the duration of your Dexa is depending on the oxygen requirement of the patient. If the patient need oxygen less than 5 days, you should give your total DEXA of 5 to 7 days. If your oxygen requirement is more than 5 days, you should give the patients a total of 10 to 14 days of DEXA. So next, we are going to talk about anticoagulant. How do we adjust the dosage? So basically, if the patient's condition is worsening, you escalate your anticoagulant. Basically, you change from your prophylactic dose to therapeutic dose. Okay, but as I say there are a lot of caveats that we need to take into consideration, which include the patient whether can ambulate or not and other comorbids. If the patient's condition is improving, we maintain the anticoagulant until the patient can be discharged from the hospital. Next, we are going to talk about anti-inflammatory. If the patient's conditions is worsening, as I said, we should consider the usage of tocilizumab with the criteria that I mentioned, which are good prognosis in hyperinflammatory phase or in CRS. Next, we are going to emphasize a little bit of antibiotics. So if the patients, it's actually the usage of antibiotics, it depends on the patient's condition. If there's evidence of sepsis or worsening markers of sepsis, including your increasing of white cell or persistent fever, we should consider antibiotic. But bear in mind, antibiotic should not be started on all COVID-19 patients on initial presentation. We should only start antibiotics when there is evidence of bacterial or nosocomial infection. Next, if the patient's condition is worsened or need higher oxygen requirement despite the optimization of the medication, we should bear in mind that there are thromboembolic phenomenon like pulmonary embolism, DVT. So in this kind of cases, we should consider to order CTPA to look for PE and HRCT to look for organizing pneumonia or fibrosis in this type of patients if they do not improve, especially on all the DEXA that we give. So this, again, I want to show you in our daily progress note, we should document whether we continue, escalate, or de-escalate our steroid therapy based on the patient's condition, the anticoagulant, and whether we refer ID for tocilizumab. The next question we are going to answer is that when can we off-tag patients with COVID-19, or when do we know the patient become non-infectious? So it actually depends on the category of the patients. If in Cat3 patients, we can off-tag at day 10. In Cat4, we can off-tag at day 14. And in Cat5 or immunocompromised patient, we can off-tag at day 21. So the day is actually calculated depending on the patient, whether it's symptomatic or asymptomatic. If the patient is symptomatic, we should calculate from the onset of the symptoms. If the patient is asymptomatic, we should calculate from the swab date where your Rtk or your PCR is positive. So next, when can we dispose our COVID-19 patient from ED? There are how many ways of disposition? Basically, there are 5 ways of disposing our COVID-19 patients from ED. So what are they? These are the 5 main disposition. First, either the patient is admitted to ICU or wards, or transferred to MAEPS, or we step down to IPR, or the patients can be discharged home, or unfortunately, if the patients pass away, they will go to mortuary. So let's say if the patient is transferred to MAEPS, these are the criteria that we take if patients fit to go MAEPS. So if they are on room air or ambulating and not on HD. Those patients that we can step down to IPR, these are the following criteria. If we already off-tag the patient and the patient still requiring oxygen supplement, but with venti-mass 40% and below. And more importantly, patients should not be on inotropic support. And those patients who need palliation, like DNR patient, we can actually step down to IPR as well. So for discharge home patients, most importantly, we must discharge them with our discharge bundles. So the question is, what is our discharge bundle? Okay, before I talk about that, we must identify the patient first, okay, based on these 4 parameters, as I mentioned just now. If the patient doesn't have all this, means that there's no warning signs of COVID-19, and on top of that, if the patient have good social support, then we can discharge the patient. Okay, so these are the clinical criteria to discharge the patients from our ED. Okay, so this is the clinical criteria. As I say, if the patient is symptomatic, you must take at least 10 days from the symptoms and at least 24 hours resolution of the fever without usage of Panadol, and other symptoms like dyspnea and also cough have improved. If let's say the patient is asymptomatic, we take the 10 days from the date of the swab. So next, we are going to talk about if let's say we already identify this patient who can be discharged. How do we discharge them with? So these are our discharge bundle, okay, that we need to provide all the COVID-19 patients that we discharge. First and foremost is the appointment, is the appointment of EM watch appointment. Next is the referral to physio, and we must also give the referral to KK if there are other comorbid to continue their medication. So in terms of medication, as I say, we should stop the anticoagulant unless there is evidence of PE or DVT in the patient. Other discharge medication we should give is our DEXA. In order to complete the DEXA, as I said just now, it depends on your oxygen requirement. If less than 5 days, your total DEXA should be 7 days. If more than 5 days, it should be 14 days. So last but not least, we should also give our patients with discharge pamphlet and call UKA and send to CMSA for pink band and also HSO. Okay, so just want to show you, this is our physio referral form that we should fill out and give it to the patient. And this is the follow-up letter if we discharge the patients that we need to fill out and give it to the patient. And this is our discharge pamphlet that we should actually give the patients upon discharge. Okay, so these are the most important thing, okay, that we need to consider. So here is just a bit of repetition, okay. In the red color box below, there's no, actually, what is the role of PCR testing after discharge? Within 3 months, actually, we do not need to repeat any PCR, okay? So as I said, emphasized just now, we should always write where the patient is discharged or disposed to in our daily progress note. So the last part of my presentation is a little bit about palliative care in ED, okay, on COVID-19 patients. So patients who have a DIL, DNR status should be given other supportive treatment like analgesia, hydration, and medication. And we should clearly define the direction of the care and treatment plan for patients. And do discuss with your EP. This is one of the example. If we already decided our direction of care is priority 3 with limitation of therapy. So when we say limitation of therapy, there are a few things we need to consider. We know that we are not going to intubate these patients, okay? But we must decide whether we need to give inotropic support or not. And more importantly, to emphasize to all MO is that we should give the hydration, the nutrition, and also the medications to the patient. And we need to decide on all these features. And at this point of time, actually, we can also decide whether we want to continue with the investigation or not, whether we still need to take the daily blood or not. So what are the priority level of the direction of the care for this patient? As we can see from here, the priority level 1 is for those critically ill and unstable patient. For priority level 2 is acutely ill but relatively stable patient. And for priority level 3 are those with advanced comorbids and high risk of further deterioration. Okay. So for the withdrawal of therapy, there are a few factors to consider in our decision making before withdrawing any therapy. If the patients, we know that they are terminally ill or have poor response to our treatment, or there are development of severe complications, or they are expected of poor neurological outcome or presence of comorbids, then we should discuss regarding the withdrawal of therapy. Okay, so as we can see in our daily progress note, we include the palliative bundle as well in our daily progress note. And that's all. Thank you very much.
Is there any question you want?
Is there any questions that you all want to ask?
Any question? Oh, okay. For CRS.
Correct. For CRS, as I mentioned just now, they are LDH, ferritin, all the criteria. You only have to fulfill one criteria to say the patient is in CRS. Okay. So if let's say your CRP is more than 100, yeah, you can say the patient is in CRS. Okay. But as I say, CRS cannot be interpreted in isolation as well. Not like you say CRP more than 100 is CRS. You must make sure the patient is in hyperinflammatory phase as well. Okay. So tally with the duration as well. And on top of that, the patient is worsening, maybe worsening hypoxemia and everything else. Okay. Don't interpret it in isolation.
Oh, for the discharge bundle, we are going to prepare the bundle lah. Maknanya the physio referral pamphlet dengan referral letter tu. Nanti Kak Ita akan compilekan semua. Yang semua tu kita baru nak bundlekan actually. So baru lately kita discharge banyak. Saya nak tanya pasal post-discharge inform UKA SMSC untuk band what for oh pasang pin okay, dia macam ni. There is a difference between being off tag and discharge. So we can discharge tapi the patient is still not off tag. Okay, maksudnya dia contohnya orang yang on oxygen, dia punya off tag dia day 14. So katalah dia dah kat department kita, on day 10 tu dia dah switch to room air like more than 24 hours for example. So parameters lain semua improve, dah ambulate. So kita nak discharge. So bila disambung kat rumah, dia kena sambung quarantine sampai off tag period of 14 days.
So means that they discharge at day 10, but they can only off tag at day 14.
So we have to call UKA for the quarantine letter and the bag. Yeah. So masa tu kita call UKA atau patient boleh jalan pergi belakang ni. untuk pasang pin band dengan HSO. Kita call UKA. Kalau after office hour ada UKA on call. Macam nak tahu kita call CMSA, diorang ada nombor UKA on call.
Discharge from ED, then we go to CMSA to pakai the gelang tu. This is something, this the new plan for us now. Kita akan pasang gelang and ventilator lah. Cukupkan the 14 days. So our MO person akan buat letter to CMSA to put for ventilator and band for what date to what date will be mentioned.
You will go on your own or it will be?
Yeah, that's right. Because it's something never been done in CMSA.
Tak, yang CMSA tu is just the UKA akan gelang and dia ada yang surat HSO tu. Itu saja. Yang lain-lain tu are by our MO.
Betul.
You escort them to CMSA. Suddenly they run away from you.
Run away.
Sebab normally yang CMSA yang pergi sana is all the walk-ins. They go there, they inform them for HSO and pasang gelang and give the ventilator. Normally that's the walk-in one lah. This is something that tak pernah orang discharge from then go to CMSA and pakai gelang and also issue a ventilator.
Ada buat few time dah.
Ada dah.
HSO home seclusion order.
Home surveillance order. Ya. Mak saya tak pernah dibuat sebenarnya.
Saya I'm not aware lah.
Oh,
Discharge from ED, then we go to CMSA and HSO plus gelang.
I think that will come up with a flow and then edit maybe at I know what you're saying.
Kita present lagi lah. Kita boleh
Be
present.
confused. Then UK will say because UK only can pasang the gelang in CMSA.
Okay,
Tolong baca yang tulis. Mata tak nampak. Kita boleh tolong baca tak?
okay. Sekejap sebelum tu. Okay, for those online, tadi Zalma was asking about kalau kita patient, discharge patient and then send to CMSA at the back. Because there is a difference between off-tech punya period dengan yang day yang kita discharge dari ED. Meaning kita mungkin discharge someone Cat 4 on day 10 of their illness. But kita tahu Cat 4 off-tech period until day 14. So orang ni kena sambung quarantine kat rumah sampai day 14. So this is where we call our UKA for the HSO punya form. So another question.
So the question is that I just read the questions for the members of the floor here. So the next question is if the patient already on Dexa 20 mg and can wind down oxygen, do we change to Dexa 8 mg terus or do we wait for day 5 to taper down to Dexa 10 mg despite oxygen requirement that are reduced? So the answer to this question we actually do not taper down straight away. Let's say day 3, you already can wind down, let's say from high flow mask to venti mask 60%. We do not taper down straight away on the same day to 10 mg. Normally, we will still complete the 20 mg OD for 5 days at least. Then only we start to taper down. But of course, if there are conditions where you need 20 mg OD of more than 5 days, let's say on day 7 only, you can only wind down, then you can consider to taper down your steroid the day after. Okay, so I think that's answer that. So the next question is that what is the cut point from Cat 4 to Cat 5? Like some patients with Cat 4 come with mild or moderate transaminitis, AKI. When do we consider multi-organ failure? So the answer of this question is actually, even though there's mild transaminitis or AKI, there's already some sort of organ dysfunction. That's why in mild AKI or mild transaminitis patients of COVID-19, we already consider them as Cat5, even though they are not intubated or on nasal prong, but with organ dysfunction. Okay. So next question is for post-COVID-19 patients, in terms of ruling out infection, which test is recommended? RTK, PCR, and what does CT value play a role in ruling out? Okay. So in COVID-19 patient, actually, there is no criteria or there's no clinical parameter that we can rule out infection. Okay. We need to see the patient as a whole in terms of the clinical, lab, and also imaging, as I mentioned just now. So if you really ask me, what is the one test that actually most sensitive to look for infection in COVID-19 patients? As we discussed with medical team, actually, we are looking into procalcitonin to look for infection rather than your others.
No,
Yes, sir.
They must have reinfection.
Oh, reinfection, sorry.
Bacterial infection.
Oh, you mean reinfection of the COVID-19? Sorry, I misinterpreted it. So for ruling out reinfection, okay, what is it, RTK or PCR, and what does CT value play? So as I mentioned just now in the one of the slide, if the patient is COVID-19 positive, there is no role actually to repeat the RTK or PCR within 3 months. Okay, means that in that 3 months time, after they diagnose with COVID-19, there's no role of any PCR or RTK. And what does the CT value play in a rule of ruling out? Actually, as far as I know, CT value doesn't play any role in ruling out, because as we know, CT value is only telling us the degree of infectivity. So yeah. So anything to add? Yeah.
Okay, for this question, so we know that RT-PCR will last for 3 months. So there is, kalau kita repeat pun memang akan positif. So now what about Rtk Antigen? So Rtk Antigen, because it's antigen, so usually it will be positive for the first 1 week. And it's supposed to be negative after that. Okay. Okay, tapi we saw some variations among the IDs as well. Okay, some even after 7 days tu, they can still repeat the Rtk antigen. But there are certain places that actually incorporate Rtk antibody. Macam dekat bawah. I'm not sure whether we have it here, but Rtk antibody is actually helpful to help differentiate whether it's a reinfection. Eventually, patient macam ni akan proceed juga dengan RT-PCR and they proceed dengan CT value tu lah. But of course, there are caveat about the CT value, that a low CT value does not always equivalent to high viral load. So there are various interpretations. So I guess if we encounter this type of patient that we are in dilemma whether they are reinfected or not, always discuss with our EP and we will discuss with the ID as well. Yeah. Next question, Chong. Is there a guideline for sugar control?
So the
on
question,
high dose?
the question is there any guideline for sugar control on high DEXA usage? Because I realize daily patient on high DEXA always end up with high sugar level, even those on non-diabetics. Okay.
Okay. Okay, so actually the gist is actually the sugar control. Of course, oral hypoglycemic agent is not the way. So like oftentimes what we can see, as long as it's not decay, then we start the sliding scale. Okay. But it's just that when their sugar level is too much high, so that dose of insulin actually can goes up to 0.2 unit per kilo. one thing is that we need to rule out, or we need to look hardly for DKA and HHS, because most of the patient, as we can see, have both of these lah, especially DKA. Yeah. Next question. Hi doctor, do we prone to get infection even after we got our vaccines? Siapa ni? Can.
So the answer is, yeah, the answer whether we can get COVID after vaccination, the answer is definitely yes. Just that the vaccination will reduce the severity of the COVID-19, means that it might prevent you from progressing to Cat4, Cat5 lah. Okay, so that's the main gist. So the next question by Shalini is the VTE prophylaxis for pregnancy with COVID is above Cat3 also. As we know, pregnancy is hypercoagulable 4 to 6 times compared to normal patient. Because Sungai Buloh start with prophylactic even in Cat1 pregnancy. And also, how long should we consider post-COVID hypercoagulability? As in how many months?
Kita discuss dengan ID.
So, to be honest, Shalini, I don't know the exact answer for this, but from my practice, actually, not specifically to pregnancy, okay, but in general, COVID-19 patients, I agree that they are in a hypercoagulable state. In the general COVID-19 patients, we only start anticoagulation when it's Cat4 and above, and we stop anticoagulations upon patients can discharge or we think that they can start ambulating already. So normally we do not continue the anticoagulation post-discharge unless in the ward or in hospital, there are already evidence of PE or DVT, which the duration of the anticoagulant is subjected from the medical side. Yeah.
The same applies to pregnant patient. If they recover, or they can off-tag and on-tag anymore, sambung anticoagulant or not, the same criteria.
Dr. Chong, just now you mentioned that
Okay lah cakap Pak. Microphone.
this one was mentioned that in category 4 with AKI and plasmatitis, we will escalate to category 5, right?
Correct.
Okay, I understand that the steroid management is based on the oxygen use.
Correct.
So in category 5, let's say nasal prong plus AKI plasmatitis, do we escalate the steroid as well, or we still stay at 8 mg OD?
Okay, so for good question, for nasal prong wise, if let's say you got already patients with nasal prong but already got mild AKI or tonsillitis, for me it's considered Cat5 already. So in Cat5 patients, for me at this point of time, if you ask me, as I said, there's no exactly rule of increasing the DEXA at this point of time, because if you say the patient still need nasal prong only, doesn't need to increase to venti mask or anything, means that for me, that the conditions of the patients, even though it's in Cat5, but it's not really how to say, in terms of oxygen usage, because as I said, the steroid usage is mainly based on oxygen requirement, right? So that's why for me, it's still maintaining the same dose. Unless there's increase in oxygen requirement, then only I will increase the dose. But if you just say that based purely on the organ dysfunction like AKI or tonsillitis, I would not increase the steroid dose. If the patient still on nasal prong and
have any
maintain
concerns oxygen worsening, yes, increase the steroid.
Correct.
If the hepatitis worsening,
yes.
So we don't have any concerns.
Correct. Agree.
To be continued.
Yeah.
And another question would be for PD prophylaxis. We understand that in Cat4, we use the prophylactic dose. Cat5, we start on treatment dose. Am I right?
Actually, as I said, the anticoagulation, whether it's prophylactic or treatment dose, is actually based on same oxygen requirement as well. But there's a caveat there, which is even though you say patient on high flow mask or modified CPAP, you can discuss with your EP to start the treatment dose with other factors take into consideration, which are patient whether can ambulate or not, other comorbids like increase the hypercoagulable state, like maybe the patient is on, underlying cancer, okay, for example, or no contraindication for the treatment dose. Means that if personally for me, I would even calculate the HAS-BLAD score for safer purposes. Even though there's no like exact contraindication, like not patient actively bleeding, but that's an objective way of seeing it. So that's why for me, very simple, you start with prophylactic dose, but those patients who need higher oxygen requirement, after considering other factors, then you can discuss with your EP to increase the therapeutic dose. Okay.
And one last question. Sorry.
Yeah, it's alright.
Let's say I have a patient which is on Cat4, nasal prong,
okay,
and then the one of the COVID bloods, the D-dimer came up to be high, let's say in the 30 to 50s. Do we change from prophylactic dose to treatment dose of anticoagulant, or is it because of the inflammation?
Your question is whether we will change the prophylactic dose of anticoagulation to treatment dose, just basically purely based on the D-dimer. The answer is no. Okay, so the answer is no. So basically, as I said, don't interpret one reading of any lab result in isolation. Okay, we see the patient in the whole, we interpret the clinical conditions and whether our lab result is supporting it or not. But mainly anticoagulation, we only consider to increase the therapeutic dose based on the oxygen requirement solely. This is our consensus.
Thank you.
Okay.
Okay, next question from Chan Liping. Hi, good morning, doctor. Would like to ask, is there any criteria for chest physio referral for inpatient? Example, patient in yellow COVID, or all COVID patients should refer for chest physio? So very good question. Liping, actually, yes. In fact, actually, we have invited them to come to our department actively to teach our patients for deep breathing exercise and chest physio. Cumanya memang ada nampak lah juga diorang pergi kat yellow COVID tu, diorang guna inhaler tu and instruct or guide the patients for that. So it supposedly become a routine because that's what we requested from them. But in case you didn't see it being done, so we will try to call them again. Okay.
Dia boleh videokan lah, beli TV ya. Orang ada rumah TV, letak TV kat tempat. On TV, okey, orang tengah exercise, tak nampak. Mungkin lah, letak orang ada rumah TV. Satu orang ada rumah TV, and video tape kan. So dia tak payah datang kan. So it's self kan, self using. Okay, in the future. Bagi soalan.
Actually, the last question is, okay, they said, okay, sorry, Dr. Faizal mentioned something about stable oxygen requirement but worsening multi-organ failure. I didn't catch the whole thing. Okay, so Abdul Muhammad. So the conclusion from here is that actually, just now actually give a good questions. He asked actually regarding whether we need to escalate the DEXA if the patient's on nasal prong but with organ failure like AKI or transaminitis. Okay, so the answer is that we only will escalate the steroid therapy or increase the IV DEXA dosage based on the oxygen requirement only. Okay, we do not actually increase the IV DEXA based on the category of the patient. Means that if the patient from Cat4 to Cat5, we increase the DEXA straight away. We do not do that. Okay, we do not have a consensus to do that. Okay, but generally, if the patient progress from Cat4 to Cat5, we expect the increasing oxygen requirement for this kind of patients. If they are increasing oxygen requirement for this kind of patient, then we should consider increasing the IV Dexa dosage. Okay, that's the conclusion.